My name's Naomi Fullett from UCL. I'm very pleased to be chairing this session on addressing failure and turnaround. So if we could have the next slide, please. How we respond to failure and facilitating turnaround is really a key element of overall improvement of performance and quality of of any healthcare system. And there are a whole range of interventions from external regulation and targeted quality improvement initiatives. But we need to understand a lot more about the impact of these different approaches. And today we've got three stellar presentations for you addressing this issue and highlighting different approaches and experiences of organisational failure and turnaround. So first up, we've got Kiran Walsh from the University of Manchester, who's going to be setting the context for us, delving into the history and setting out a number of ways of thinking about failure and turnaround, particularly from a capability perspective. And then we've got two presentations based on recent and current research on different approaches to achieving turnaround. And the first of these is a presentation by Jean Ledger from UCL and Chris Sherlock-Johnson from the Nuffield Trust on our recently completed study of how trusts respond to being in the special measures regime and evaluating the interventions within that regime. And the final presentation is from Ross Miller from the University of Birmingham and Sarah Morgan from Guy's and St Thomas's NHS Foundation Trust. And they're presenting on their study of another particular approach to turnaround, organisational partnering and collaboration. And of course, the current COVID-19 crisis has challenged healthcare organisations as never before. And in response, we've seen fundamental and extremely rapid changes in the way organisations have worked together to reorganise pathways and deliver care. And as we move into the recovery phase, questions have how best organisations can support their staff and work together to restart services while maintaining physical distance, and also in parallel maintaining capacity to deal with any potential future waves of COVID. These questions really come to the fore. And in parallel, regulators are rethinking governance and regulation. So we hope that this session will provide perspectives that will be helpful in these discussions and future planning. So turning now to our presentations, what we're going to do, we're going to run straight through these, and each presentation has a maximum of 10 minutes, and I will keep people to time, as the presenters know. And so we have time at the end for a panel discussion. So first of all, and sorry, I should say to presenters, you're all doing it very nicely, keeping your video off and keeping to mute. Thank you very much. So I'll hand over to Kiran now for his presentation. Thanks.
That's great. Thank you, Naomi. And hello to everyone joining and watching the session in recorded form. I've been researching this area of failure and turnaround for almost 20 years. I first got involved in it when I was an advisor to the Bristol Royal Infirmary Inquiry back in 2000, 2001. And since then, I've researched inquiries, but I've also been an advisor to a number of inquiries, most recently the current infected blood inquiry, and done research projects around failure, turnaround, and major performance challenges. These are really dramatic circumstances, big events which have huge implications and often terrible costs as well in human terms for people involved, both patients and families, but also for staff and others. And if there's one point I want to make in my presentation is that it's really important we learn to look beyond, if you like, those events, however awful and florid they are, and to think really quite analytically about why they happen and about the nature of the organisations in which these things occur. On the next slide, I put two covers of inquiry reports separated by pretty much 40 years. The Ely Hospital inquiry in Cardiff was pretty much the first modern form inquiry in 1969 into the mistreatment and abuse of patients in a long-stay mental health institution. And on the right-hand side, the first Robert Francis inquiry into failures in care in Mid-Staff's NHS Foundation Trust. And what's striking when you set these two alongside each other, and you'll see this, if I move to the next slide, you'll see this. I've set things that people have said in those two reports alongside each other. And what's really striking is that there are absolutely enduring themes, and that the things the reports say and even the ways they say them are almost interchangeable. When you read them, they talk quite descriptively about the problems that have been found and the issues to do with resourcing and overcrowding and poor reporting and lax standards of care. But they also, as you'll see from the next slide, talk a little bit more thoughtfully about issues you might regard as to do with the people in the organisation and the way they behave, issues of attitudes, behaviours, cultures, beliefs, and the way those people interact with each other, but also with others outside the organisation. And as you'll see on my third slide, the common theme, and I think you'd find this if you looked at almost any inquiry report over the last 40 years, the other thing that they commonly speak about is the way the organisation has been led and governed, and the way that the people in charge of the organisation have exercised their function. The things they've done are often the things that they have failed to do. And those criticisms of Ely Hospital back in 1969 and the Hospital Management Committee and the Regional Hospital Board are absolutely parallel to those of the Foundation Trust Board in 2009 for mid-staffs. But one point I'd make is that I don't think the science of doing inquiries has advanced a great deal in those 40 years. And a criticism, I think, of inquiries is that they're largely led by lawyers. They're often very oriented towards fact-finding, but I'm not sure lawyers are great at understanding organisations. And so the inquiry reports are often descriptive, atheoretical, and don't necessarily really get to what's gone on under the surface in the organisation. On my next slide, I've got a really simple model of failure and turnaround, and it's the model I think I began with, where performance gets worse, then something happens, an egregious event to promote a crisis. All kinds of things can happen. In Bristol, it was the death of one particular child. In mid-staffs, it was the unfolding public interest in the local newspapers. But something happens to provoke a crisis, then there is intervention and turnaround, and then the organisation is improved. But the thing is, when you go and look at failing organisations, they don't seem to follow that simple trajectory, particularly naturally. Sometimes they spend a really long period in decline. Sometimes failure is not acute, but chronic. Turnaround turns out to be really difficult and complicated to do, and it doesn't always lead to improved performance. So we need to try and think more analytically, is I guess my point. And on my next slide, I've got some examples of the things we find people saying cause performance decline and failure. And when you read accounts, often of people involved, you get quite florid descriptions in which individuals figure quite large, either as heroes or sometimes as villains, where there's a fascinating and slightly kind of bewitching account of crisis and drama and sometimes quite extreme behaviours. And you get a real sense of how traumatic it has been for people to live through those organisations. But it doesn't tell you why it happened. If you look beyond that, you'll often hear people's accounts talking about markers or symptoms or signs of failure. So they talk about relationships, internally and externally, about financial deficits, about targets. We came up with, and others have come up with, lists of hard and soft indicators of performance might help you to predict or understand when failure might be likely to happen. If you look beyond that, you sometimes see what I've described on this slide as secondary or primary causes, which are much more about the organisation and its attributes or its capabilities, the nature of its leadership, its approach to strategy, the environment it exists in changing through competition or policy or innovation, and the organisation being distracted. And underlying all that is my last set, these aspects of the organisation to do with its culture, attitudes and beliefs. You often find words like introspection or arrogance or myopia used, the sense of paralysis or abrogation of responsibility in the organisation. Fundamentally, this sort of failure to understand, to learn, to adapt, and to change. If I move to my next slide, the other thing that I think is really interesting is that you can see failure in two different organizations and see them respond to it quite differently. So in some organizations, faced with failure, they ignore it, they deny it, they rationalize it, they challenge, they manipulate the data, or others may accept it, reflect on it, explore it, respond, take ownership of it, and tackle it. And this is what I've described on this slide as the self-regulating response to failure in organizations which recognize, are willing to change, are open about their problems, and have, crucially, internal capacity to do something about it. And what I've described as the failing response to failure, which is organizations that believe in their own success, that don't take kindly to learning from elsewhere, that think about their past more than their future, which quite often hide the data, and crucially, which don't have that internal capacity to do something about the problems that they're faced with. So I guess my point is that it's really helpful to have a model. And there are plenty of models out there, but the model I'm going to talk about on my last couple of slides is one that rejoices under the name absorptive capacity. If I move to this next slide, yes, I don't really like the term absorptive capacity, but it comes out of the literature on management learning. And the idea of the learning capacity of an organization is that it's how the organization recognizes and understands knowledge, how it then assimilates and adapts that knowledge to its own circumstances, and how it then applies that knowledge to the way it works. And people sometimes describe this as exploratory learning, transformative learning, exploitative learning. And the argument is that it's this learning capacity which is what's crucial to an organization's ability to do what I described as have a self-regulating response to failure. But what shapes the learning capacity of an organization is some factors that you might describe as internal to the organization and some which are external. So I've got 3 boxes on this next slide, which are the internal factors. And you can argue about, or even if you really want to, change the labels, but broadly, they're 3 things. They're the sort of mental models, attitudes, cultures, beliefs of the organization, the structures and processes that exist in the organization, the way it gets stuff done, and the strategies of the organization, its higher level responses to achieving change. And there are also, on the next slide, 3 external factors which seem to shape that learning capacity. One of which is that the organization's approach to brokering internal and external knowledge. So how it interfaces its own knowledge with the knowledge it gets from elsewhere, from a literature, from research, and from other sources. Another is the nature of its relationships, what's described here as learning relationships with other organizations. And a third is the environment it exists in, the nature of the environment and the way in which that shapes its ability to develop absorptive capacity. Now, the model looks a bit complicated, and I'm happy to listen to arguments that we should try to simplify this a bit. But the crucial thing, I think, is that it really helps to have a model that enables us to describe and understand the capabilities of the organization and the way those capabilities influence its ability to change and to respond to failure. Those capabilities, I think, shape why it ends up in decline and failure, but are also really important to any real process of substantive turnaround. If I move to my last slide, it's easier to look for a simple solution. It's easier to leap to blame people, and that's quite often what happens. It's easier to pin it to a particular cause. It's all because of the internal market, or because of foundation trusts, or because of the way regional health boards work, or whatever. And I think the truth is the answers about these organizations are often complicated and a bit complex, but that having an approach that thinks about the organization's capabilities is really helpful in securing some kind of enduring and lasting turnaround. So back to you, Naomi.
That's great, Kiran. Thanks so much for that context setting and getting us to think to move away from a kind of blame game to a more complex view of how we help organizations turn around. So if we move to our next slide, I'm really pleased to introduce Jean and Chris presenting on this study of special measures. Thanks.
Thanks, Naomi. So hello, everyone. And we're going to discuss a study that we only recently finished. It was part of the Rapid Service Evaluation team, which is a partnership between the Nuffield Trust and UCL. And if we can go to the next slide. So a large team of us undertook this research, bringing together qualitative researchers, quantitative analysts, and health economic researchers. So moving on to the next slide. What's the background to this evaluation? What did we do? Well, as Kiran's alluded to, the special measures for quality regime emerged following the Keogh review into avoidable mortality in 2013. So we're aware that when trusts have serious performance failures, they may be placed in special measures for quality. And this is designed as a support regime to bring about improvements in struggling organisations. From our policy interviews, we were told that it's meant to be a time-limited regime, and it's worked out in collaboration with the Care Quality Commission and NHS Improvement. What happens when trusts are placed in special measures for quality is they get increased oversight from regulators, but they also get specific interventions from NHS Improvement to help them tackle problems. There is also a watch list of challenge providers who are organisations deemed to be at risk of entering special measures for quality, and they are also entitled to receive support. So how did we study this? If we go to the next slide. We undertook data collection from December 2018 to January 2020. We wanted to look at these regimes and how organisations responded to them, and we wanted to increase understanding about the impact of specific interventions on trust ability to achieve quality improvements over time. Now, the specific interventions that trusts receive from NHS Improvement is they can be sent an improvement director whose job it is to help them develop a quality improvement plan and support organisations, particularly working at the top of organisations with leadership teams and boards. You can be buddied with another organisation. You can bid for funding to bring around quality improvements internally. And there's often other changes like changes in leadership and deep dives in particular service areas such as A&E. If we go to the next slide. Our methods were to do a literature review on the looking at what's already been said about organisations that are high and low performers. And then we undertook analysis of national data sets to find out how trusts were doing over time, who's been in the regime and for how long. And we did 8 in-depth case studies with mixed methods. So if we go to the next slide. As Kiran's mentioned, there's a lot of complex reasons why organisations end up troubled and needing additional support. And many of these are historical issues and they've been going on for a long time. So issues around workforce turnover, patient safety issues not being addressed, they get flagged up in repeated CQC inspections over time. And there's a perception then in the regulatory system that some organisations really need extra outside support and some challenge if they're going to sustain quality improvements. So if we go to the next slide, Chris is now going to discuss what we found from the national data.
Thank you, Jean. So there have been 62 trusts up until September last year. There have been 62 trusts that have been either in special measures for quality or on the challenge list. 36 have been in special measures and 26 have only been on the challenge list. The large majority of these are trusts offering acute services, as you can see, about 54 of those compared to very few mental health or community providers. The diagram below just shows how the special measures and challenge provider list overlap. And of those 15 trusts that have only been special measures, 9 of those were Keogh trusts that entered when the regime began in 2013. And since then, most trusts enter special measures when they're already on the challenge providers list. In fact, of that 21 in the middle, 18 have come going straight from challenge to special measures. And just 4 trusts have re-entered the special measures, having previously left. Now, in the next slide, we look at how long trusts spend in the improvement regime. The 2 charts at the top show how long trusts remain on the challenge list and in special measures, challenged on the left and the special measures on the right. The median time to spend on the challenge list is 11 months compared to 25 in special measures. So, for example, just under half the trusts in special measures are turned around within 2 years. And there's not necessarily a quick turnaround of trust on the challenge list either, since, as we've seen in the previous slide, that many of these subsequently enter special measures. If we combine all the times trusts are either challenged or in special measures since July 2013, we get the lower chart. And that shows really in a period of over 6 years, just over 6 years, 18 of those 62 trusts, which is about 30% of them, have spent more than half that time under the regimes. Now, if we go to the next slide, which asks the question about whether there are any particular characteristics of these trusts when compared to everywhere else. Well, there's no important differences in the age of patients they see, nor in the size. Trusts in the regimes have significantly greater proportion of admissions from rural areas and fewer from most deprived areas, but that's possibly linked in the sense that rural areas tend to be less deprived anyway. And fewer of the trusts are foundation trusts, with about 50% of them compared to 70% of the remainder. If we move on to the next slide, so using available national data, we analysed outcomes for these trusts. And our particular questions were, firstly, how does trust performance and activity compare against national outcomes when they first enter the regime? And secondly, is there any evidence that the support programmes trusts receive affect these outcomes? And the list of measures we analysed is shown here, and they're a mixture of quality metrics and workforce statistics, things that are readily available in the public domain. So we move on to the next slide. This slide shows the results for a few of these indicators, and it's looking at where trusts are when they enter the regime and how outcomes subsequently changed relative to national trends. Now, the relative point is important here. For example, we know that nationally, against several of these measures, poor outcomes have been on an upward trend over recent years. So rather than just be interested in outcomes improving in absolute terms, we're also interested in whether support under the quality regimes has reduced any upward trend. So there may still be an upward trend, but it may have reduced substantially from what it was before. So the coloured arrows represent where the relative trend sits amongst the special measures and challenge trusts. And what we have found is that trusts have a significantly higher rate for A&E breaches on entering the regime. That's the top row. And the trends improve during intervention, and they also seem to improve after leaving. However, we see little influence on referral to treatment times and cancer weights. There's some improvement in delayed transfers of care and mortality while within the intervention, and sickness absence rates start to improve later. Now, if you look at the next slide, just looks at summarises results of analysing the STAR survey. And on the left-hand side, we have the different domains into which survey questions are grouped. And trusts entering the regime have significantly worse results for 6 out of the 9 domains. And once they have left, improvements have been seen in 5 of them. So that's more than half. Okay, so back to Jean.
Thank you, Chris. So I do a lot of organisational case study research, and this is really interesting for understanding how organisations respond to interventions and policies and what's happening internally in organisations. So we conducted 8 case studies, and I'll give a very brief overview now of some of the things that came up when we interviewed staff, reviewed documents and did observations in those organisations. Firstly, it's really important to say that staff and often leaders felt very shocked and sometimes devastated by being placed in special measures for quality and receiving notice about their performance and that they were seen as poor performers. And the regime is also placing a lot of administrative pressure on senior teams and staff. Yet over time, we did hear that people felt that there was some relief about being placed in special measures because it forced examination in the organisation and turnaround and time and some headspace to think about quality. So it was seen by some as a necessary catalyst for positive change. If we go to the next slide. What about the improvement interventions from NHS improvement? Well, very briefly, I won't cover these all in detail, but in terms of having improvement directors coming in and support organisations, they often worked closely with senior leaders and the boards, and a coaching style was generally preferred, and it was important that there was a good relationship with the improvement director and the top team of the organisation, but at the same time there were questions about how long should an improvement director come in and work with an organisation, and when should they step away. And in terms of buddying up with other trusts, we found a real mixed range of views about this. Some organisations had been partners with other trusts and they didn't really feel that that was an appropriate match, but they did like learning from organisations who'd been through turnaround, made lots of changes themselves, and gone on to be stronger in CQC inspections. So they like learning about good practices and people who've been through this like them. If we go to the next slide, what we found is when trusts enter special measures or when they've had a very bad CQC report, they are often overwhelmed with 200 things that they need to do. So we categorised into 8 overarching themes where they tended to put most of the attention on performance and quality improvement. And I just wanted to flag that there was a lot of attention on to improving organisational culture and staff engagement. And things had to be tackled, such as high workforce turnaround, staff well-being, examples of bullying, and there was a lot of emphasis on really the leadership becoming visible to the organisation and listening to staff and engaging them better. Next slide. So this is looping back really to what Kiran was discussing earlier. Did we find that with some organisations that had exited special measures or been challenged and gone on to get good or outstanding ratings via the CQC and to sustain improvement, were these organisations developing new capabilities internally? Were they using new knowledge to help them improve? And we found evidence of this. There was some really systematic use in some organisations of using data not just to meet targets, but for quality improvement, to have early warnings of when things might be going wrong and to really take a preemptive approach to quality and patient safety. So things like dashboards. There was discussion about quality improvement running from war to board or being a golden thread throughout an organisation. So a lot of investment in using new quality improvement knowledge and tools.
Jean, I'm going to have to ask you to wrap up.
Yeah, of course. So very quickly, thanks Naomi. If we just go to the next slide, a key take-home message for trust is that staff needed to be considered a top priority. And if we go to the next slide, please. It's difficult for trusts to prioritise a large number of recommendations, and they need that headroom to make change. And we would recommend avoiding duplication in the regulatory process. Thank you.
Great, thank you very much, Jean and Chris, for that rapid overview of our rapid study that's brought out some really important points. So finally, I'd like to turn to the second of our double acts, Ross and Sara, to share with us their thoughts and findings from their study of partnering. Thanks. Ross, you need to come off mute.
Classic with first of the day. Sorry about that. Good afternoon, everyone. What we would like to do for the remainder of this afternoon is present to you a flavour of research that's currently ongoing, that's exploring a particular approach, a particular intervention that's associated with turning around and improving organisations, and that's partnering, and sort of particular focus on inter-organisational collaboration across NHS providers. So we'll present a flavour of what we've found so far. So next slide, please. So yeah, just an acknowledgement to the funder and just to sort of showcase the team that's involved in this project. And I'll move on to the next slide. So just to set the scene around our studies of partnering for improvement. So let's sort of connect that to the context that we're at the moment. That you know, Jean's presentation for, you know, referenced buddying as an approach to sort of improving organizational performance, and that's very much associated with a sort of, you know, preferred approach of regulators in turnaround. But I think it's important to situate this idea of partnering in the wider context of policy landscape that's placing greater emphasis on collaboration. We're in a landscape that's now, you know, moving towards or currently have integrated care systems and very much promoting cross-sectoral collaboration and systems-based approaches. No more so than the past few months with COVID-19, and lots of discussions and reference points to rapid collaborations and working together in response to the pandemic. So our project situates and talks to the sort of failure and turnaround perspectives, but I think it's important for us to reflect on the sort of moves in the landscape to encourage greater collaboration across providers. Next slide, please. So why do we enter into this space? I think what you found, I think Kiran's presentation alludes to this point as well, that you know, collaboration, partnerships, integration, lots of terms that have been used interchangeably, lots of ingredients for success that have been put out there proposing, you know, solutions to key problems. But actually, when you look a little bit more detail, we do lack quite a lot of understanding, a lot of depth in terms of the underlying dynamics and sort of conditions that are required for collaboration and partnering for improvement to happen. So I think that our project, that whilst it's, you know, you hear these terms a great deal, there's quite a lot of work still to be done in terms of getting into the underlying dynamics and under the surface of what's going on and why. Next slide, please. So that's precisely what our project's trying to do. It's provide a range of useful intelligence. We're doing quite a lot of desk-based work, assessing theoretical and empirical evidence, particular focus on inter-organizational partnering at this stage. Fieldwork was paused with the pandemic and so forth. So we're going to resume our fieldwork really from over the next few weeks in terms of capturing perspectives from within the NHS and also from other stakeholders about where these types of approaches can be best utilized. Next slide, please. So here we've got quite a wide-ranging typology. I'll go from the left, move to the right. I think one of the key sort of entry points into partnering is to consider the motivations. Why do that? That's often, in this context of the presentation, been regulators maybe encouraging or mandating different partnering arrangements, but there's also likely to be other dynamics at play as to why you might enter into a partnering arrangement. Competitive advantage, collaborative advantage, keeping afloat. There's going to be other things at play that'll sort of influence our motivations. So that's an important point for us to consider and capture. Then we move into the different types of partnering arrangements, the entities. So we've got a scale of from budding right up to full-scale mergers and acquisitions. And what we're trying to say here is, within these different types of partnering arrangements, you're likely to find these different dynamics within the box at play. So here we're making some tentative sort of causal links around what you might expect in order for these particular partnering approaches to be successful. So I think what you see in the previous slide, you've got the importance of leadership, you've got the importance of workforce and engagement. You know, these are the types of domains and factors that we'll need to consider, and particularly as you go more into fuller integration in your partnering arrangement, you're likely to really have to deal with these. Connected to our methodological approach, we've also got to consider these wider contexts and mechanisms. So often you've got to tease out the key processes. What do you need for this to work? Is you've got to build trust, you've got to maintain trust, you've got to try and reduce and manage conflict, you've got to try and think about capacity and capability, which two presentations have highlighted. So these are the types of principles and processes that we've really got to sort of get clearer understanding of how and where these will work in practice. Then we move on to the right-hand side. We've got different outcomes of things that you'd like to see, what you would hope to see when you're entering into a partnering arrangement. And what you've got a lot in the literature is the difficulties of capturing how far different partnering arrangements can achieve these different outcomes. And lastly, just at the bottom, we've got this temporal dimension. So I think the key aspect of thinking about partnering is the dynamic process. There's different points that will require different dynamics. And so our review is seeking to sort of capture those and give some guidance around what you might expect to do at particular moments in time. So I'll move on to the next slide, and I'll hand over to Sara to provide some additional thoughts.
Thank you, Ross. So I bring a perspective that's from the NHS itself, and I think partly as we've been looking at this work and what the COVID response has shown us is that partnering and this approach to collaboration has been very important in our response to that. One of the elements of that is purpose. So what we've seen is collaboration around common purpose and the importance of that. So we've been looking at networks and come together at both a sector level and a local level around a critical care network, and also providing mutual aid around PPE, and that partnership's been really important. The people, so all three presentations have talked about capabilities. One of the things that has started to emerge in some of the research that we've been doing for this project is around the capability that you need for collaboration. Is that the same as the capability we've had in the last 20 years as the capability of a competition? And I think that is something that will be very interesting for us to look at. What is it that we need of our leaders and our people, and this importance of place. So my organisation is a large teaching hospital, and usually we have patients from all over the country. What we've seen recently is that COVID has narrowed that down to our local population, our local relationships, and the importance of the integrated care system that we find ourselves in. So having that lens on the purpose, the place, and the people is going to be really important for us going forward. So I just wanted to give a few reflections from the NHS as is and the healthcare system, and also the post-COVID world. So with that, I'm going to hand back over to Naomi.
Thank you very much, Ross and Sara, for bringing that all together. We're now going to turn to our panel discussion. So I think we've got a small and perfectly formed audience. So do feel free to turn your videos on, as it would be lovely to see you. What we're going to do is, to give you a bit of time to think about your questions, I'm going to ask the first one. But then please do indicate if you have got a question through virtual hand raising, because I can see at the side on the participants list who's got their hand up. I hope this will work. If that doesn't work, just do the old-fashioned thing. So just to kick us off, with this kind of focus that the session has had on organisational capabilities, how can we better support the development of these for turnaround in organisations that are challenged? And perhaps I can ask Kiran to kick off with that, and then we'll come to Jean and Sara.
Well, I mean, as you'll know, Naomi, I've also spent quite a bit of my time working on the role of regulators and working with CQC and its predecessors. And I think one of the things I've learned from doing that is that the people who work in the oversight body, in that case CQC, but actually we've also been talking about interventions from organisations like NHS England, NHS Improvement and others. The people working in those roles need themselves to have the capability, the capacity, the understanding and the resources to develop capability in the organisations they work with. I think we've all seen and observed, if you like, wham bam turnaround efforts where you drop in some bright, enthusiastic, fantastic hero chief executive or improvement director, and they run around doing stuff. Often what's described in the improvement literature as retrenchment in the turnaround literature as retrenchment activities, which is fixing the big problems. And then they leave, and they haven't changed the capabilities of the organisation at all. And so after that, things tend to go back to the way they were before. On the other hand, you still need that focus on function, don't you? So it's not enough simply to send in, kind, thoughtful organizational development specialists who can help the organization to learn about itself, because it's got problems to fix. And it's finding people in the regulators or in the intervention teams who combine those sets of skills around function and capability.
That's great, thank you. Jean, I think, was next.
Hi, thanks. So I think this is really interesting when organisations are troubled, and it came out in our research and it's there in the literature. Very often we did see use of external consultants coming, you have the improvement director, so you have external experts to the organisation. But when we actually explored how are you bringing about an embedding change over time around quality improvement, some of the organisations that were really trying to sustain change, they'd made improvements, but they wanted them to be ongoing regardless of changes in leadership. They were investing things in constant staff training and quality improvement, things like quality improvement academies, and almost bringing an internal listening culture and quality improvement culture into their organisation. So they were building capabilities around that. And it was quite interesting. In one discussion, they said, we have staff turnaround, people move on. So we need to constantly be training people in our approach to quality improvement to really embed it. So just having people come in and leave is obviously not enough, but it takes dedicated resource and leadership to do that internally, I think.
Thanks, Jean. And Sarah?
Yeah, I would agree with that. I think, so I started in operational management and now in the fluffy stuff of organisational development. So I completely agree with what Kiran says, because I think you need both of those things. You need the technical skills plus that ability. But partly the challenge we have is that most organisations are left to do that themselves. There isn't what we describe it as operational excellence. So we training up our managers to have that real technical ability to be strong operationally, but also bring the coaching side and compassionate leadership side. But we do that as an organisation, and I think there is a trick missed where we don't do that on a larger scale and actually start to collaborate around training people in both of those sides. So I think that might be an opportunity going forward.
Great, thanks. So I've seen questions from Sara Scobie and from Raj Jain. Thank you. So Sara Scobie.
Hi. Yes, Sara Scobie from the Nuffield Trust. Thank you very much, everyone, for really interesting presentations. I wanted to explore a little bit about the use of data and information by organisations. And Jean, I know you mentioned that organisations were shocked by finding themselves in special measures. But I mean, given how they get there, perhaps that's a bit surprising. And were there changes in how effectively organisations learned to use the information available about how they were functioning?
Jean, do you want to come back on that?
Yeah, I'll say something and hand over to Chris. We did look at this question, thank you, Sarah, about did trusts use data differently? And there was evidence of actually really from all levels of organisation, bringing data monitoring throughout the organisation, and not just using data to perform and make sure you're hitting certain national targets, but really to just be really more sensitively monitoring what you're doing. But there are massive data problems in terms of time to do this and resources. And I think it was very much organisations were learning how to better use data to measure the things that matter to them. Chris might have more thoughts on that.
Yeah, I think there has been quite a lot of focus on the standard metrics. I think that's something which, and moving towards perhaps more tailor-made, bespoke type collections of data is useful. I know NHSI do some work in that, but they don't sort of make it visible. And things that are more targeted, I think, towards the actual problems that they're actually seeing, so that you can actually, rather than say, oh, we must be doing all right now because our mortality rates are so much better, it's actually to be sort of looking at, you know, what was the problem in the first place? Can you measure that? And can you see an actual improvement in that coming later? What we have seen also, I think, is there's been a lot of, again, driven by NHSI, it's been an initiative to actually monitor data continuously and not just rely on sort of annual or monthly snapshots, and then they do an arrow going up or down as to whether it was better or worse than the previous month, but actually to look at things much more continuously and to look and to be able to really, I think, much more analytically more intelligent way of looking at the data. It does require good analytical expertise within these organizations, which is hopefully another point altogether. But you know, there's with a fair amount of support coming from bodies like NHSC and I, hopefully that sort of thing can be, you know, addressed, and hopefully in the future.
Thanks, Chris. And Raj, I think you had a question. Raj, you need, can you come off mute so we can hear you? Thanks.
All down. Menu bar. Zoom meeting. To navigate.
Can you hear me?
Yes, we can hear you. Thanks, Raj. Go ahead. Oh, you're on mute again, I think. You're still on mute, Raj. Raj.
Naomi, why don't you move to another question?
Okay, Raj, I'm afraid we'll have to move to another question. We'll come back to you. Who else had a question? I can't see any virtual hand raising, but oh, Sandra. Thanks.
Yes, hi Naomi. It's less of a question, more of a comment. I thought it was very interesting that Jean and Chris said about the emphasis on staff as being key. And as a lead governor in an organisation that first buddied with an organisation that was not doing so well, and then eventually merged or took over that organisation. I think that's a really important point, that you do the change in capabilities is really important, and the only way you can do that and embed that change over time is actually to pick up those individuals, particularly the staff from an organisation that they have been labelled as failing, and they feel very angry and upset about it, and to actually build those capabilities by taking all that's good in what they were doing clinically and saying how good that was, and then actually buddying them with other staff to try and make those improvements come into the merged organisation, but also to make them feel valued. And that change in culture is absolutely key. And if you don't do that, you leave those staff feeling embittered and you don't build capability at all. And I think that's really important, that staff are so key to making this work.
Sandra, thanks for those reflections. Do any of our panel want to add to that? I was thinking Sarah Morgan might, with your experience, Sarah.
Yeah, I completely agree that staff are, we're a people business, and so our staff are absolutely vital to everything, but it's that sense of agency and enabling them to also feel part of something, which I think sometimes gets lost along the way. At the moment, we do have quite a big sense of agency, so I feel that we've got an opportunity to capitalise on all this work and really think about how we take staff with us on whatever comes next, really.
Great, thank you. And oh, Tara, and just so people know, we will be finishing at 1:30, so we have time for a few more questions. So Tara, thank you.
Thanks everyone for a really great series of presentations. I just wondered if any of the research studies had looked at the role of the media, both local and national, because obviously there's a kind of holding to account and surfacing some of these issues, but whether there's a sense of, kind of being put in the stocks, and how that supports or not sustained improvement.
Great question. Which of our panel members would like to answer that? Kiran, I don't know if you can answer that from your inquiry work.
Yeah, I mean, the media, politicians, and other sort of stakeholder groups like patient groups often play a really important role in initiating and surfacing, if you like, concerns. I don't think the research tells us a lot about this. I am really cautious about asserting that the sort of, you know, the process of inquiry serves the interests of patients and families. I think it's actually quite a traumatic process for patients and families involved in major inquiries, and I'm not sure that they get catharsis, reconciliation, redemption, and a sense of true accountability necessarily at the end. I think inquiry processes are really quite flawed tools for achieving that. There's no question that the media play an important intermediating role in these events. I would observe, though, that the behaviour of people is remarkably insensitive to issues of reputation. So some work we've done looking at places that have been rated inadequate in maternity services, and we picked maternity to look at because it's an area with a lot of if you like, user agency, an opportunity to determine where you go, a very strong set of established user voices. And we just couldn't find any evidence that people moved away from providers that had been labelled as inadequate, even when they had other maternity service providers that were relatively accessible close by in major conurbations. So it's complex to understand the relationship people have with their local organisations, and it's about more than just what the CQC says about those organisations.
Thank you. Ross, do come in.
Thanks, Kiran. Thanks, Tara. I mean, just following on from that, I mean, what's coming out of the sort of searches within different systematic searches? Not a great deal on media per se as a factor, but I think that connection with the influence of public opinion, the role of the public, the community in shaping, let's take partnering, for example, how that might proceed, I think is a really important one, and hasn't had, you know, as much coverage and attention as it could. I think a lot of the evidence, it's workforce, it's leadership, it's analytics, but engaging in that space, the public interface, and that the information that's processed there, I think it's really important. There's quite a gap, actually. So that was just an observation.
So something definitely for future research to look at the role of the media.
Absolutely.
Great. So Raj, I think you're off mute now. Do you want to come in with your question?
Yes, sure. Thank you, Naomi. A great series of presentations. Thank you, guys. Really very thought-provoking. My question is around support, backup support systems. So technology, finance, procurement. You know, I know you talked a little bit about the resource management, but I just wonder how much time you had investigating, really looking at the detail, you know, what kind of the processes that leads up to failure, not having those backup support processes as well. Just wonder whether there was enough time to look at those in detail.
Another really good question. So on support services, does one of our panel members want to come in? Ross?
I'm happy to chip in again. Thank you, Raj. Yeah, it's a really good question, and one that, again, is often in the backstage, as it were, regarding if you're trying to generate, from a partnering perspective, generate sort of organisations working closer together, and what you need for that to happen. There's a lot of work that's done, you know, in terms of the back office, as it were, that's a key sort of stage in which a lot of what happens gets played out. So not as much, again, linked to the media, not as much coverage on that as perhaps it could or should, but it's a clear sort of sort of space, a context which will determine, you know, how successful partnering intervention is going to be. So that's from my reflections on the evidence we've gathered so far.
Thanks, Ross. And Jean wanted to come in, and then we'll come to Sarah.
Just very briefly, Raj, there were lots of early warning signs, and one thing we did pick up on in our research is actually about the entire estates management, technology and equipment of these organisations, and that was a key area where there'd often been a lot of neglect and build up within the system. So if we're thinking about early indications of warnings, and a lot of trusts nationally have had problems with this, but that became quite a talking point in our organisational case studies, because they really had some challenges around poor estates and equipment that needed updating. And it's important not to overlook that, because that led to other problems like delayed diagnostics.
Thanks. And Sarah Morgan.
I think I was just going to sort of echo what Jean said, really, because I think that what you could see often in these cases is very stripped back support functions, very, very lean organisations that are almost trying to operate on the bare bones of the support they need. So often people cut back on HR processes, for example, thinking, well, the managers can do that themselves, but you know, not recognizing that sometimes having that expertise and having support in the right areas and having a good backlog maintenance program or whatever it looks like is a crucial part of running a solid, safe organization. And I think safety in the round is something that often gets missed or forgotten or not paid attention to enough. So I think I would have expected to see that, Jean, actually.
Thank you very much. And I haven't got any more questions, and we're just running up against our end time. So I'd really like to thank our speakers for really fantastic presentations and for the pre-work that people put in to kind of bring them together as a whole rather than just have three separate presentations. And thank you everyone for joining and your thoughtful questions. And I very much hope that you enjoy and encourage you to look at the HSR UK website for the fantastic array of material that's going to come up over the next few weeks, and then the plenaries. So I really hope that you enjoy the rest of the conference. Thank you for joining.